What you're about to experience is one man's quest to see beyond the tumultuous period we're in and to envision what lies just beyond our grasp, yet well within our reach. Welcome to Larry Rifkin's America Trends, where the future has arrived, and it's just in time.
Welcome back to America Trends. Larry Rifkin and John Kropsic. And John, while one could argue that the healthcare system overall is in a world of pain itself, one of the aspects of it that's most troubled are these rural hospitals. I don't know if you've been reading about this, but nearly a quarter of rural hospitals are on the brink of closure.
I hadn't even known about that. I know in our area, a lot of hospitals are being taken over by the bigger hospitals as, you know, things are growing bigger and bigger, but I hadn't heard that hospitals were closing.
Yeah, well, the consolidation that you're talking about is definitely underway, and that's pushing up prices because now you've got these big healthcare systems that are negotiating prices that are pretty exorbitant. There's a lot going on in healthcare, and we're going to continue reporting on it, John. I've got another podcast in the waiting that I think people are really going to want to hear about the healthcare system overall.
Yeah, well, our healthcare system really needs a revamp. I mean, I wish heads would get together in Washington and really look at what's going on and really figure this out. I mean, this is something that is affecting us all. You could go broke going to the hospital.
Oh, absolutely. And you know what I find very interesting, John, and again, we'll pursue this more in another podcast, but it's all a payer-driven system. I want people to think about this. I'm in a bed in a hospital, and you're in the bed next to me. Depending upon who's paying for your care,
right, the insurance rules,
there are different protocols for every patient. Does that make any sense?
No, it's crazy.
And how do the clinicians keep all of that together when, in fact, they want to care for the patient? They don't want to think, how am I going to code this? Or why would I do this when it's not going to be reimbursed? I mean, it is just rather insane. It really is.
And then they burn you on, well, a doctor looked at you that was out of network, so you got to pay full
Well,
for
those
that.
are called
And
surprise
Yes.
medical bills. We talk about that, too. So there is so much about healthcare that we'll continue pursuing
But
as part
closing
of America
hospitals,
Trends.
that's serious in areas that are probably underserved anyhow.
Exactly. Well, think about it. There's a new report. 21% of rural hospitals are at high risk of closing. That equates to 430 hospitals across 43 states, employing about 150,000 people. So, John, think about it. If you live in a remote place in America, your hospital may already be downsized, consolidated, or closed. And this is a centrifugal force for these communities. The hospital plays a major role in the lives of people throughout America.
Oh, sure it does. I mean, look in our community how much they play and you know, they help throughout the community.
Well, imagine if you're living at a place that is rather remote and the next hospital over is 50 miles or 60. I mean, that's an issue of life and death. There's no question
an
about
emergency.
it. Well, John, from 2010 to today, there have been 107 rural hospitals closed, and the numbers even be a little bit greater now. And again, we heard the projections. So we really want to talk about this issue. It's a really important one. I think we found a tremendous gentleman to talk with us about this. His name is Mark Holmes, and he's a professor in the Department of Health Policy and Management at UNC, the University of North Carolina, and the director of the Sheps Center for Health Services Research. And he's coming along to explain what is going on. So if you live in a rather faraway place and you're listening to us, we live in a place that has a lot of hospitals. There's no question.
Yeah, we're lucky, but then you got to figure out whose hospital is covering what.
Exactly. And the quality of care is a differential. I mean, there's no question about it. But what if you had no hospital at all?
Yeah.
And the hospital, of course, as we talked about briefly, is an educational center. It's a place where people go to rally around for various causes. Hospitals play many roles. And if they're not there, then a community really is deficient in so much about its own public life.
Just the fact that in an emergency you have to travel 50 or 60 miles to get somewhere is, that's horrible. That's
exactly.
horrible.
I mean, there are some that are a shell of their previous self where they leave in place a portion of what was there. But you have to wonder, ultimately, can you really grow by subtraction? I mean,
Right.
Is that something, can you even preserve the quality of the services that you have remaining in that community? So let's talk about it all with Mark Holmes here on America Trends.
With us on the line on American Trends is Mark Holmes, Ph.D. He's a professor in the Department of Health Policy and Management at the University of North Carolina Gillings School of Global Public Health and the director of the Sheps Center for Health Services Research. And I know, of course, Professor Holmes, that you look at rural health care in a very specific light. And I'm doing a lot of reading, of course, in anticipation of talking with you. And I'm realizing that there's truly a crisis going on as it relates to rural health care. I know we talk about macro health care issues in America, but this one seems to need a particular spotlight.
So we've seen a number of rural hospital closures happening across the country. And each one of these closures can have a devastating effect on the community that the hospital is serving. When you think about what this means from a health standpoint and the loss of the emergency room, often other services that have disappeared with the closures, such as labor and delivery, surgery, but other things such as home health, maybe hospice, maybe a primary care clinic that the hospital is also providing, long-term care, such as a nursing home. These can really have an important and devastating effect on the community and its desire to be healthy and get the services they need. In addition to the effect on the health, though, you also have to think about the economic aspect. And when these close, you can have a number of people, 150 in a typical closing hospital, or employees are out of work. And what does that mean for, the ripple effects across the community? The florist and the people who would pick that up and bring that by, the groundskeeper, the landscaping company, any food service industry that's providing for serving the hospital. And then also think about even the broader effects. When we look at a factory that's trying to decide where to go, they may be only focused on communities that have a hospital. If a school system may be facing challenges recruiting young teachers if there's no hospital there. We think about retirement communities and places that are trying to be, serve as sort of as a magnet for new retirees. Well, they're going to want to have a rich and set of health services that are available in that community to meet the needs of a newly retired population. And so it has this sort of broader effect beyond just the health aspect.
Oh, absolutely. I want to get into some of the economic aspects of this later, to the fact that rural America tends to be, from what I'm reading, a little bit sicker, a little bit older, poorer than the rest of the country, and a lot of health disparities already exist. And without a hospital as an anchor for things like higher rates of diabetes or child mortality, loss of productive life earlier in their careers, I mean, this has got to be an incredible challenge to many communities.
Yeah, you're absolutely right, Larry. When you have a population that tends to have more chronic conditions, doesn't have a health insurance that's as generous as you might have in more urban settings, the incomes are generally a little lower, you may face barriers for transportation. These can really make it so that a closure, even if there is an alternative hospital 15, 20 miles away, it can still be so far away to not provide any services, and that if I don't have a car or reliable transportation, that hospital maybe doesn't take my health insurance, maybe I'm uninsured, and I was able to work something out with the local hospital but can't with the hospital that's farther away and doesn't know me. Maybe they're not connected with my primary care physician, and so I have a tougher time coordinating care. All these can add up to make it an environment where when the local hospital closes, it's going to have a larger effect on these more fragile communities and populations.
And the southern impact seems so great. When I'm looking at it, Alabama, their rural hospitals are in financial distress, about half of them. the highest percentage in the country, and at least 36% of the hospitals in places like Arkansas, Georgia, Mississippi are in financial jeopardy. How much of that relates to the fact that many of these states decided not to get involved in the expansion of Medicaid?
So when you do a map of hospital closures and financial distress and lay that against each state's Medicaid expansion decision, there tends to be a fair amount of overlap. As you mentioned, the South tends to have the rural hospitals facing the largest financial challenges. The South as a region was less likely to expand Medicaid. So a lot of people have looked at that and drawn a straight line and said, well, clearly Medicaid expansion is important. And there have been some studies that have supported that. On the other hand, if you look 10 years ago and did a map of where rural hospitals were less profitable, that map would look very similar to what it does today. So whereas Medicaid expansion probably would help rural hospitals, it's not the primary reason that we're seeing this closure rate.
When we do look at it, I guess it begs the question that I have to ask you as an expert in this area: how many hospitals does the U.S. healthcare system need? And are these the right hospitals in the right places, or are they the right hospitals but in the wrong places, unfortunately, given the ability to sustain them with dwindling populations and a poorer community?
So it's a great question to think through. How many hospitals do we need, and are some of these closing rural hospitals ones that maybe, if it closed, it wouldn't be, the community might not feel it. Now, that's easier to do in the abstract in a room with an Excel table and an office, and you can sort of do the math at that standpoint. Of course, if it's your community, then that can be, have large effects. It's not dissimilar from what do we do with this railroad crossing? Is this one where we just put up a sign? Do we want the lights? Do we want the gates? And if it's in your neighborhood, I may be more inclined to say, we don't need the lights at all. It'll be fine. But if it's on my street, I may want the full protection. I think the other thing that's relevant here is that the rural hospital of today is becoming less and less an inpatient facility and more of an outpatient facility. About three-quarters, for most hospitals, about three-quarters of their business, their rural hospitals, are coming in an outpatient setting. So these are clinics, emergency room, things like that. Whereas in larger urban areas, it's about half their revenue is coming from an outpatient. So, the typical rural hospital is largely an outpatient facility with some inpatient beds attached to it. So as that payment system that we've been using for years for hospitals hasn't been able to adapt, it was built on a system where that wasn't quite that kind of mix. It was built for hospitals that were closer to that 50-50 range. And so as we become more and more outpatient-based, that's probably one contributing factor.
And if these hospitals are leaving a community, and perhaps some of them are not necessary, or maybe they're adapting to changes, becoming smaller, more clinic-like and such, what about doctors? In terms of the shortage of the workforce itself, how many doctors are leaving these areas to go to other areas where the needs are perhaps greater for their services, or they can be better compensated?
So we know that in addition to rural hospital closures, workforce disparities are a major challenge facing rural America, and particularly, often in physicians, particularly among behavioral health and mental health is where it's most acute. When we think about some of the causes of death that are most disproportionate in rural areas, one of those is suicide, particularly by firearm, and so that could draw a straight line from that to shortages of mental health professionals in rural areas. And so we can see that these difference in the distribution of where physicians and other providers are located can have health effects and sort of underscores the disparity between rural and urban health.
And even if the hospital stays open, how difficult is it, Mark Holmes, for them to stay up on all the capital needs that really do today change with such rapidity? Are they able to invest in technology and electronic medical record and imaging and all of these advances that seem to be so profound within the medical experience?
A lot of healthcare today is very capital dependent, and whether they're electronic health record systems or updating the facility and the building for the new way that we deliver care, or replacing some of the, in some cases, rather old buildings that are serving as these rural hospitals, those require lending and capital in order to make that loan in order to finance the new purchase. That can be much more difficult for a small, rural, independent hospital, particularly as community banking has also been on the wane, and we have fewer community banks and more, large institutional banks. That's one of the potential advantages for rural hospitals to join a system is the access to to capital that is available as being part of a 20-hospital system, which might not be as a part of a independent hospital.
And is that a trend as well? Because we see it here. I'm talking to you from Connecticut, and we see Hartford Hospital in Connecticut and Yale New Haven gobbling up the smaller hospitals, some of which they're making as subsidiaries and satellite operations with fewer of the services that once were considered part of a comprehensive hospital.
One of the trends that the healthcare industry as a whole has been undergoing over the last 10 years is a rather marked consolidation, both vertical as well as horizontal. And in this case, the larger systems merging and acquiring smaller hospitals. A less well-known and appreciated trend is repeated among physician offices and clinics to build market power, to help manage risk that we see with value-based payment. These are all trends that are continuing to impact rural communities with a wide variety across the country of where you are. In some states, there are very few independent rural hospitals left. In others, most of them are still independent, and that can also, as we've discussed, lead to differences in access to capital, but also clinical practice, everything from payment. It's going to be much more an advantage to negotiate with an insurer if I represent a 40-hospital system than if I'm a small hospital in the corner of the state.
And are most of them still nonprofits, or are some of them becoming for-profit hospitals?
Across the country, most hospitals, both rural and urban, remain nonprofit or government-owned. A minority are for-profit, but those tend to be less common.
When we do look at it, the support of a 24/7 emergency department where standby staffing costs are really high and volumes are relatively low and reimbursement comes nowhere near to covering expenses seems to be one of the most difficult things and biggest challenges for these rural hospitals. And yet that would seem to be one of those services that when you lose it, having to sky somebody to another hospital or travel 100 miles when there's nothing else around would be a real challenge and concern for these rural communities.
When a hospital closes, and particularly a rural hospital closes, the most immediate and visible impact is the closure of the emergency department. The popular press is littered with stories of a rural hospital closes and within a day or two, and sometimes even hours, there's a 4-year-old who's choking who shows up to the ED and it was closed and they couldn't get to the next closest hospital in time, or someone's having a heart attack and can't get to the alternative in time. So that closure of the ED is the one that is most visible and has the biggest, most immediate effect on the community. That's why there's a lot of interest in thinking about new types of rural healthcare providers. This would have to be building something new that doesn't exist today. In some urban communities in particular, we have these freestanding emergency departments. Medicare rules and how these are paid for are very prescriptive. State laws can vary in terms of how they can operate. There's been interest at Congress and in MedPAC, the Medicare Payment Advisory Commission, in thinking through what could this new rural freestanding emergency department look like? How could we pay for it? What would be the kinds of services we would want? How big do we want them? Where should they be located? We probably don't need one 4 miles from another hospital. How far should they be? What is the type of volume we would expect? These are the kinds of questions that people are kicking about to think for exactly the reason that you indicated, Larry. The closure of the ED can be the most immediate impact. And so how can we build that ED service with a new type of approach to financing it to meet the needs of that community?
Mark Holmes is with us, a professor in the Department of Health Policy and Management at the University of North Carolina and director of the Sheps Center for Health Services Research, knows an awful lot about rural health care. You know, we did a podcast several months ago on 5G and its importance to so many things in our society, one of them being remote medicine. A lot of us may not really understand what the implications are, but it seems to be most important in rural areas. And there's this question as to whether 5G is going to come on faster in rural communities simply because the need is greater. So telehealth, how important a tool is this advancing technology to some of the issues and problems we're discussing?
Telehealth shows a lot of promise, and there have been some places where it's starting to finally pick up steam. The challenges to a wider implementation are both technical as well as regulatory, and there are lots of rules and payment methodologies that make adopting and delivering telehealth a little more challenging than some people like myself think it should be. But from a technical standpoint, we continue to make improvements in terms of how well it can work in rural communities. When the broadband rolls into a rural town, one of the first things that gets connected is the hospital. And so that can be really attractive from that option. And if you think of like a teletrauma or a telestroke, someone comes into the emergency department, they're having a stroke, they need something to be read quickly by someone who understands, an expert in stroke care, that can be transmitted quickly back to the teaching hospital who can, prescribe the course of action. Or maybe it's, a trauma where we need to read the MRI or the X-ray quickly and get that feedback, where we might not have a radiologist on call at 3 in the morning in the rural hospital. Things like images are really big and more difficult to pass across broadband. They have a wider, a higher bandwidth in order to do that. And so having that faster connection to healthcare facilities in general in rural areas is really important. But we also need to think about telehealth in a more broad standpoint, and this can be everything from telepsych, where I can go into a room and sort of video conference with a psychiatrist or psychologist who is in a urban setting. Others are this notion of telemonitoring. So if I have heart failure, maybe I want the scale to send in my weight to my doctor every day, and so that they can look and say, oh, you're gaining weight, we need to adjust your diuretic, kind of thing. So although connecting the hospital in is really important, oftentimes the challenge is less facing the hospital but more about elsewhere throughout the town. And in rural communities, you can, these anecdotes of the parking lot of the library being crowded with teenagers because that's the best Wi-Fi in town, and people sit in their car, submit their homework, and then go back home where they don't have that broadband capability. So, oftentimes the focus is on connecting that hospital. We need to think more broadly about the impact or the availability to the community writ large.
How much is the fiefdom mentality a problem in trying to form new approaches to getting care to rural areas? I was reading where Nebraska Medicine, they convened a rural hospital consortium, and they shared best practices, and they talked about their challenges and streamlining redundant services. And then I was reading about the University of Alabama at Birmingham taking on administrative responsibilities, sharing specialists with rural neighbors. How creative are people getting given the crisis that we're seeing in these rural communities?
So one of the exciting things and why I love studying rural America is the creativity and innovation, and solutions are often driven by with an asset-based approach. What do we have in our area that we can use that is something that really works for us, something we can capitalize on? And so you get these really innovative, creative models that may be really important in that community, but might not spread as well to other areas. Think about how you might design a healthcare facility in a very seasonal area. Think like a rural ski resort. Your demand for orthopedists in the winter is going to be very different than it is in the summer. Or likewise, what it might look like in a beach community where you want to be sure dehydration and sunburns and jellyfish stings your experts are there in the summer but are less relevant in the winter. And that's going to be very different from a community where maybe it's more isolated. And so the ability to think about these different models is really important from the rural community, and understanding, all right, we're 15 miles from this, that's close enough for our needs for this, but we're 50 miles from this. How can we do this? Do we need to try and get an oncologist to come in, once every 3 weeks in order to meet that need? Or do we need to, organize some sort of transportation? And so there's a van that leaves here every Tuesday that takes us over so people can get their chemo and bring them back, kind of thing. The challenge with that is that the healthcare industry is often highly regulated, most of the time for very good reasons, but isn't always as flexible as we need it to be in order to meet these needs. Case in point being the freestanding emergency department. The way that Medicare reimburses makes it challenging for an independent freestanding emergency department to be profitable and operate. And so that's why Medicare would have to rethink and redesign this purveyor, or actually more accurately, how Congress would have to create this new type of provider in order to make it viable. So this fiefdom of the rural community, it's a very collaborative environment where people will share what they're doing and what they're trying. It won't always work, and unfortunately some of the times it does. It's inhibited by state, federal, local regulations that are well-intentioned but may not be as flexible and adaptive as we need them to be.
So these accrediting bodies and states often have certain prescriptions that may not fit the current model. And I'm thinking about that in the context of the federal response. I mean, we know that these hospitals are closing at an incredible clip. I think it was about 20%. So the question is, what is the Congress? And we know they have been doing a lot about many things, but what are they doing? Is this Rural Emergency Acute Care Hospital Act going anywhere, and would it help?
I think there are a number of different bills that have been proposed and proposals that have been offered by executive agencies as well, and CMS, the Centers for Medicare and Medicaid Services, has a whole rural health strategy where they're rolling out changes to regulations that are designed to help support rural hospitals. The Health Resources and Services Administration has a number of initiatives that they're pursuing to identify and support struggling rural hospitals. It's a big problem with many root causes, which means the solution is not going to be easy as either. It's exciting and comforting to know that so many parts of federal as well as state government are trying to figure out what can we do about this. And, it's expanded beyond that. There are many insurance companies that are trying to think through how can we support the system for their rural members and that they're covered, or rural-based foundations that are supporting initiatives to enrich and support rural health care more broadly, invest in leadership that can, be creative and think about best practices. So Congress has some strategies they're looking at. Federal agencies have some strategies. But everyone's going to have to do something in order to really turn the needle on this. It's going to take collaboration across federal and state and private partners in order to stem the tide here.
Do you think that we're responding to it with the right amount of force and resistance to what we're seeing, or is this just another one of the problems that we see fester for a long time, and we wake up to an even greater problem, another 5 years go by, and nothing materially has changed? I mean, how quickly do we need to act?
There's a lot of activity across the country that's trying to address the issue. What we need is more action. Convert these great ideas and get them implemented so they can start making a difference.
If there was one idea or two, you said it was multifaceted, so it's not easy to just lay it at one particular doorstep. But if there was one or two things that we could do with some pace, what would you think would be most important?
Medicare is one of the largest payers and is the primary payer for most rural hospitals. And if we're getting serious about supporting rural hospitals, thinking through redesigning how we reimburse them, how we support them, we have to start with that. And it's gratifying that CMS has made this a priority over the last couple of years, and there's some exciting ideas coming out on a variety of aspects from that. There is no one silver bullet, but I think having Medicare really taking a hard look at what it can do, as we're seeing as of late, I think is some of the most promising activity we've seen as of late.
Is the altering of what they call the Medicare wage index a part of that, and could you describe what that means?
The wage index is one of the components for how Medicare reimburses certain kinds of rural hospitals, about half of them. And it's driven by the prevailing wage of the area. And the idea is that if you have to pay more to employees in one area than in another, then Medicare should pay more in places where the wage is higher. In its annual update this year, Medicare has proposed adjusting that mechanism and increasing the wage index, which is how this actually gets implemented into the payment system, increasing the wage index for the 25% of hospitals that have the lowest wage index, and essentially increasing the amount that they would get from that standpoint. Because Medicare has to be revenue or cost neutral, that would be paid for by reducing the wage index to those hospitals that are in the highest average wage area. So it would increase the revenue and the payment to the hospitals that are receiving the least due to being in the low wage areas, but it would pay for that by reducing the amount going to those in the high wage areas. So it's set up as a political challenge in that 25% of hospitals support it, 25% of hospitals don't support it. I think the idea would tend to increase the revenue for these lower wage hospitals. It does face political headwinds due to the nature of how it gets designed.
Understood. Let's go back and close with this issue of the economic impact. Hospitals are often the economic drivers, not only in rural communities, but even in communities here in Connecticut. They've become, in many cases, the largest employers. And reading the per capita income falls 4%, unemployment rate rises 1.6% when a hospital closes. And, of course, you brought out all of those ancillary problems that result in terms of the impact on so many other businesses. I don't think we can overstate the impact that has on a small community where the local hospital has been just a central organizing principle for that community.
I mean, we think about what the role the hospital fills in a rural community is we've touched on the health aspect, we've touched on the economic aspect, but there's also the sort of leadership idea. And whether it's everything from sponsoring one of the softball teams, but also convening the mission of the town. And so if there's a challenge facing the community, and whether that's an opioid overdose spike, or maybe an increase in suicide or teen pregnancy, or pick a health challenge, usually it's the hospital that's the convening force behind some call to action. Sometimes they might be the driver and be the chair of the task force, but oftentimes they're more in a supportive role, and the mayor or the local hardware store owner or the superintendent may be leading this effort with the hospital in the background, providing the staff, the space to meet, the meals, all the sort of other things that you don't think about that actually are important to making a community effort go. And this community benefit aspect of rural hospitals, I think, is also often invisible. And when the rural hospital closes, the community may lose this leadership element. Everything from the person out front leading the charge and saying, this is what we need to do about this, to the resources behind it and underwriting the effort. And so really, although most people can easily understand the effect of the rural hospital closure on the community's health, it's that broader stuff that's just as, if not more, concerning.
Well, we have an emergency clearly in rural America, hospitals closing across the rural states and struggling counties that rely on them. It's a really important issue, and I'm so glad that we on America Trends could find such an expert, Mark Holmes from the University of North Carolina, to join us. Mark, if somebody would like to read more about this, I know you put out reports. Can you give us any direction to get to some of that material?
So our website, you can search for North Carolina Rural Health Research Center. There's a lot of research for others in the what's called the Rural Health Research Gateway that collects research across multiple rural health researchers and is designed to make it accessible to the public. And then a third website would be RHI Hub, Rural Health Information Hub, which also has a lot of information for your interested listeners.
Okay, well, thank you so much for being with us today on America Trends.
All right. Thank you so much, Larry, and thanks for looking at this important issue.
America Trends podcast is part of the MHNR Network, mhnrnetwork.com.